This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Today our topic is hypertrophic cardiomyopathy, and we have a very special guest. I mean, she is an incredible cardiologist. She's a heart failure specialist at Cedars-Sinai, and she's been very involved with the American Heart Association as well as the American College of Cardiology, particularly in the field of hypertrophic cardiomyopathy, and been involved in the committee dressing up the guidelines, that we have that were just released this past November. And with me today, we have Dr. Michelle Kittleson, MD, PhD. Michelle, thank you very much for agreeing to do this podcast with us at MyHeart.net.
Delighted to be here. Thank you.
Well, hypertrophic cardiomyopathy, as we know, is a highly treatable genetic disease, and it's associated with normal longevity and excellent quality of life for the majority of patients. It's estimated that approximately 750,000 people in the U.S. have this condition, but only 1 out of 7 have been diagnosed. And delayed and misdiagnosed put the patient at risk for sudden death and heart failure. And we know there's a lot of barriers to early diagnosis. I mean, it's a disease that has a various presentation. It's also a varying degree of progression at different age. The symptomatology is very nonspecific, and there's all kinds of interpretation of the echocardiogram, which is one of the main diagnostic tool that we have to make this diagnosis. So today with Dr. Kittleson, we want to provide you with educational material to really promote dialogue between patients and their doctors. We want to discuss testing and treatment options and the risk and benefit of these options to enable the patient to express their own goals. So, Michelle, when I kind of graduated from UCSF, my God, it was so long ago, 1986, and even early into my career at UAB, I mean, it's like hypertrophic cardiomyopathy. We called it all kinds of different names and acronyms. I mean, it was IHSS, it was ASH, it was HOCM, and maybe that's part of the reason why we made it maybe even more confusing, and particularly we didn't include even all the pathology that we have with hypertrophic cardiomyopathy. So let's see if you could explain to us a little bit, what is hypertrophic cardiomyopathy, or HCM? What's the prevalence, and what different phenotypes do we have?
Sure. It's actually a fascinating story historically that comes from these different terminologies. So even as early as the 1600s, physicians recognized that patients who died suddenly had really big hearts. And isn't this strange? And then it was in 1958 that a physician Dr. Tier had a series of patients, 9 patients who died suddenly, and their hearts were very thick. And then there were surgeons who would operate for aortic stenosis, but they'd open up the chest and the aortic valve looked fine. It was this thickening of the muscle below the aortic valve. So that's where the term idiopathic hypertrophic subaortic stenosis first came about. Then 1960s, now we have echocardiogram, at least in some early form. And then you could see the septum was thick, and that led to the asymmetric septal hypertrophy. Then echo got even better. And wait a minute, it's not just the septum, the whole heart can be hypertrophied. So that's where the more global, more general, accurate term hypertrophic cardiomyopathy came into existence. And it clustered in families, and through beautiful genetic studies by 1990, the genetic underpinning, single gene underpinning of hypertrophic cardiomyopathy was established. So it's a really beautiful history of discovery, culminating from observation, physical exam, imaging, and finally genetics. So when you think about it, hypertrophic cardiomyopathy is exactly what it sounds like. The heart muscle is too thick. In a way, it would seem like, how could that be a bad thing? More heart muscle, better heart muscle. But it's bad because if you look at under a microscope, the heart muscle cells are not beautifully arrayed in an organized fashion. They're chaotic, they're disorganized, and they're in the wrong place. So having a thick heart muscle is a problem because the heart muscle can't contract contract like it's supposed to, and the electrical signals get messed up as well, as we'll talk about. So the prevalence of it. So it's felt to occur in 1 to 200 to 1 in 500 people, but just as you note, the prevalence is probably underestimated because there are so many people that may be walking around not realizing they have the condition because they are asymptomatic. The phenotypes, it can occur with thickening of the septum, thickening of the entire heart, thickening of just the apex of the heart. There's a lot of different variants and varieties that may or may not be associated with different genetic variants as well.
So basically, we have an unexplained increase in the wall thickness, of the heart muscle. The cavity of the heart muscle is actually kind of small, or even, or normal. But so what happened? Is it a disease of the muscle fiber? I mean, how does the muscle get so large like this?
So a bit of that understanding has come from the genetic mechanisms, the understanding of the genetic mutations. There's basically 8 genes that are most commonly implicated, and they're all involved in the contraction cycle of the cardiac muscle, the myosin, the actin, the tropomyosin, these various filaments that are involved in the excitation, contraction, coupling of the cardiac muscle don't work properly. So it's a problem of the heart muscle working too well, contracting too much, and then leading to hypertrophy or enlargement of the cardiac muscle. And what's the interesting part of it is that the heart muscle can hypertrophy for other reasons, right? Why do people lift weights? So their muscles get big. Why does the heart muscle get big? Well, sometimes it's because it's pumping against extra force. Like if there's aortic stenosis or high blood pressure, the muscle can become thicker. The sine qua non of hypertrophic cardiomyopathy is that the muscle is thick and there's no reason to explain it.
Great. So what's the effect of this increase in the thickness on the cardiac function? If we think about, you think like the heart muscle is really contracting normally, but is it all true? And what happens to the relaxation when you have so much muscle and when you have some fibrosis sometimes associated with this disease?
So when you think about the major consequences of having a heart muscle that's too thick, we think about obstruction, diastolic dysfunction is the 2 major things you think about. So when the heart muscle is too thick, that thickening of the septum, which is most common, actually gets in its own way. So the heart gets in its own way, obstructs itself when it contracts to get outflow of the blood to the rest of the body. So there's this dynamic outflow obstruction as the heart pumps. That's the dynamic part. The outflow, the blood exiting the heart, gets obstructed by the muscle that's too thick for its own good. And that obstruction can lead to problems with lightheadedness, dizziness, shortness of breath. The second problem, as you mentioned, is this fibrosis. The heart is stiffer than normal. And because it's stiffer than normal, the pressures in the heart can go up. And if the pressures in the heart go up, then there's more likely to have shortness of breath related to that. Also, if the heart rhythm is not perfect, the heart relies so much on being in a normal rhythm to promote the cardiac output of the heart muscle. If the heart rhythm goes off, like with atrial fibrillation, it can become a real problem. So if the heart muscle is too thick, obstruction of blood flow out of the heart, stiffening of the heart muscle, consequences, shortness of breath, lightheadedness, worse if there's arrhythmias. And the other things we think about is myocardial ischemia. So when we think about ischemia, which is decreased blood flow to the heart muscle, we most commonly think, there's a blockage in the heart artery. The blockage is giving someone angina. Put in a stent and everything's good again. This is a different kind of ischemia. This isn't caused by one of those blockages in a big artery where you can pop open a stent. It's in the microvasculature, the little arteries that are in the heart muscle just don't form right for whatever reason in patients with hypertrophic cardiomyopathy. They don't respond properly to the signals to dilate, to deliver more blood to the heart with exercise. So patients can get chest discomfort, angina, that's not your garden variety typical typical angina, but unique to hypertrophic cardiomyopathy. And the final thing we think about is not just is the heart muscle a problem, but the mitral valve apparatus is askew, is awry. So the mitral valve, which controls blood flow from the left atrium to the left ventricle, is inserted not quite right, which leads not only to problems with the outflow of the blood to the heart, but also some leakiness of the valve, which can then promote more shortness of breath. So it's a bit of a vicious circle that you have a thickening of the muscle, you have some mitral regurgitation, you have some increased pressures, and it goes on and on and on, causing more problems.
Well, that's great. So you've mentioned a little bit about some of the presentations, but you have, obviously this is a disease that started in childhood and progress, during adolescence, and usually manifests, itself in young adulthood, or I think young adulthood in the mid 30s to 40s. Of course, it's all relative, but so you can have some patients that are completely asymptomatic, and yet you have some patients that can present with sudden death. What is the whole spectrum of presentation? What should we be thinking when a patient presents, with this condition?
That is the challenge. That is the challenge of this. One of the many mysteries of hypertrophic cardiomyopathy is why, when essentially the thickness of the heart muscle, for the most part, is established by late adolescence, that's a few gene variants, gene mutations are different, but for the vast majority of people, the thickness of the heart muscle is established in late adolescence, yet all patients don't present in late adolescence. Some present later in life into middle age. And I do discover as I get older, middle age, the definition of that gets older as well. But let's just say in the 30s, say 40s. And why is that? No one knows. But the way I like to think about it is there's basically three ways that people can present. There is the most horrible way, which we've all heard about on the media, the athlete at the peak of their career, the greatest promise of their life, has a sudden cardiac event while playing competitive athletics. In fact, it's the most common cause of sudden death due to the heart in athletes. So that's one very dramatic way that one can present. And then in those people, were there symptoms preceding? Sometimes yes, sometimes no, which is why we'll talk about a high index of suspicion is so important. If you have the next type of presentation, which is more of the symptomatic but not serious symptoms, which are chest discomfort, lightheadedness, shortness of breath, shortness of breath with exertion. That's so hard in a way because you have a young person who has chest discomfort, shortness of breath, dizziness. Well, it's probably a vasovagal or probably anxious. It's so easy to write these things off to something else. A physical exam can sometimes help. In the classic, most famous anecdote I'm aware of, Dr. Eugene Braunwald himself diagnosed his colleague, the surgeon, Dr. Morrow, the one who established surgical treatment for hypertrophic cardiomyopathy. He diagnosed him, Dr. Braunwald, diagnosed Dr. Morrow with hypertrophic cardiomyopathy based on his physical exam. Those were the days of the giants. So to empower us, yes, it can be diagnosed on physical exam. And then an EKG is often really helpful. It's not going to look normal in someone with hypertrophic cardiomyopathy. So a high index of suspicion, even in a young person who has chest discomfort, shortness of breath, fainting, dizziness, is to delve deeper. And then the third means of presentation is those asymptomatic people who will come to medical attention, either because someone heard a murmur, someone got an EKG for some other reason. I had a patient once who was a first responder who got an EKG because they were testing out the new machine in the firehouse. And that's how he was diagnosed. So there's all kinds of ways people come to presentation, or they're a relative of someone who's been diagnosed. So sudden cardiac death, the way you never want someone to present. The cardinal findings, chest discomfort, shortness of breath, dizziness, where you should have a high index of suspicion to look further. And then the asymptomatic people who have an abnormal test or a family history.
Well, that's great. So far we have a condition that has an increase in thickness of the muscle, most of the time involving the middle part, of the left of the heart, which is the septum, separating the left and the right ventricle. Although sometimes It can affect different parts, right? Like the apex or sometimes the mid walls, which are, dreadful. It involves, this disarray in the muscle fibers with some fibrosis causing some obstruction, to the heart, dysfunction of the valve, some problem with the heart relaxing. People get short of breath and sometimes you get ischemia, mostly in the most endocardial, layers of the heart, the most inner portion of the walls, and causing the shortness of breath as well as chest pain. Well, that's great. So what we were going to talk a little bit about how do we work up these patients. Let's say you have someone that is referred to you, for hypertrophy. You start mentioning obviously the history and the physical that Dr. Brownwell did. I've never had kind of a physical, like this, before, but what else do we do, or what do we get at the history that could be maybe pointing toward hypertrophic cardiomyopathy?
Yeah, I think the key to the history is, again, chest discomfort, shortness of breath, fainting spells are classic, but it's also the company it keeps. So chest discomfort, that's exertional. Shortness of breath, that's exertional. The fainting is interesting. It could either be more of a whenever I get dehydrated, whenever it's hot outside, I faint, or someone started me on a vasodilating blood pressure medication and I started to have fainting spells. Or I was exerting myself very strenuously and I started to faint. So there can be different characteristics of the cardinal symptoms. A family history is really important. And here's how I like to do a family history. Oftentimes patients will say, does anyone in your family have any heart problems? And they'll say, yeah, my dad died of a heart attack. Well, and what age was he? 40. So if you write down on your little notepad or type into your electronic medical record, Dad, MI 40, you've done the patient a disservice, right? Because if the first degree relative, the father died of a heart attack, what does the heart attack mean? Does it mean a myocardial infarction? Does it mean a coronary event? Does it mean sudden cardiac death? Heart attack to a lay person is not necessarily a myocardial infarction to a physician. So when I was like to delve deeper, your father died of a heart attack. He was 40. Was he sick for a while? No. First time he ever got sick. Oh, what happened? Was he in the hospital? No, they found him at home. Did he ever have an autopsy? Trying to delve deeper. Was it truly a sudden cardiac death? Other red flags for sudden cardiac death are, well, they were swimming and they drowned, but they were a really good swimmer. Or they got into a car accident. There was no one else on the road. They slammed into a fence, and they were driving. So you think about other corollaries for sudden death when you're taking that very careful history, particularly for people who died suddenly, because it is autosomal dominant. You'd expect one every generation, multiple family members affected. So that's often very useful. So those are the things I really like to get on the history. The other things that's important to get on the history is towards your differential diagnosis. So we talked about how there's a thickening of the heart muscle. It's an unexplained thickening of the heart muscle. But there's two ways the heart muscle can become unexplainedly thick. One is there's just more muscle there. That's hypertrophic cardiomyopathy. These cells are doing the wrong thing. There's too many of them. The second way is if there's something abnormal infiltrating into the myocardium, making it look thick, but it's not all heart cells there. It's something else, some other stuff. And that can come from other hereditary conditions like amyloidosis, where the amyloid protein infiltrates. There's other things we memorize in medical school and promptly forget, except for before the boards, like rare diseases like Pompe or Friedreich's ataxia or Danon disease. These are glycogen storage diseases, lysosomal storage diseases, where abnormal things are infiltrating into the heart muscle. What's the red flag to tell you I might be missing something else? Well, there will still be a family history. Also look for other organ systems. Hypertrophic cardiomyopathy basically only affects the heart. These other things, there might be skin issues, there might be neurologic issues, there might be kidney issues. So skin, nervous system, kidney issues. Think about something else is going on that isn't my straightforward hypertrophic cardiomyopathy. So that's where the history comes in as being extraordinarily helpful.
What about the electrocardiogram and the famous echocardiogram, which is such an important tool to make our diagnosis?
Yes.
Not perfect, but we'll talk about this.
Yeah. I mean, thank goodness for the echocardiogram. I remember again, studying for the boards and memorizing the late peaking systolic murmur of the outflow tract obstruction. That's worse if you stand, squat to stand. And I mean, my head is spinning because, gosh, I'm just not Dr. Braunwald when it comes to physical examination. But fortunately, we don't all have to be Dr. Braunwald, because now we have the gold standard of the echocardiogram. So really, you hear any murmur on physical exam in conjunction with exertional chest discomfort, shortness of breath, fainting spells, family history. The EKG looks not quite right. Left ventricular hypertrophy, abnormal axis, abnormal rhythms. You're going to go to the echocardiogram. And the echocardiogram, as you said, is the gold standard. You're going to look on the echocardiogram for two main things. You're going to look for the thickness of the heart muscle. Normal is 12 millimeters or less. Abnormal is really 15 millimeters or more. And to a lay person, you could say 12 versus 15 millimeters. Is that really so significant? Yes, the heart is so smart. The heart is so constant. Everything, if you are above 15, there's something not quite right. So 15 millimeters or more of left ventricular wall thickness increased, you're concerned there's something not normal going on. That's the first thing you're going to look for. And then, of course, the pattern. Is it just the septum? Is it both walls? Is it the mid cavity? Is it apical? Is it the right ventricle? That's the first thing. Second thing is you can measure the outflow tract obstruction. So back in the days of the giants, they could listen on physical exam to elucidate an outflow tract obstruction. Then the giants went to invasive measures. They put catheters in people and looked for obstruction. Now, in the beauty of 2021, we can put an echo probe on the chest and not stick needles into anyone and figure out if there is an increased gradient across that outflow tract caused by that thick muscle getting in the way of the heart when the heart's just trying to pump blood to the rest of the body. Is that thick muscle getting in the way, causing acceleration of the blood through the outflow tract and therefore an obstruction. So the two things you're going to look for: thickness and outflow tract obstruction.
Very good. Now, echo, of course, is a very good tool. Is there anything else that you do with the echo? For example, we used to do these maneuvers while we were doing the echo with using amyl nitrite, Valsalva. I guess we don't do that so much anymore, but we do the stress echo and the exercise echo. How do you do that in your practice, Michelle?
Yeah, it's actually, so the step one is, does the patient have a gradient? Gradient across the left ventricular outflow tract, suggestive of that dynamic outflow obstruction. Because if they have shortness of breath, chest discomfort, plus a gradient, your management is going to be very different from if they don't. So it's really key, because that is a hinge point in the management. So if they have a gradient, and what's that defined as? Greater than 30 is considered, 30 millimeters mercury is considered a significant gradient. If they have that at rest, you're pretty much done. They have a gradient. Okay, now I know which management plan algorithm I'm supposed to go down. On the other hand, what if they don't have a gradient at rest, but they still have a lot of symptoms? You think there's something going on here. Either their symptoms are from something else, or I'm missing the gradient. So you want to bring out the gradient. So exactly like you say, there are maneuvers you can use to bring out the gradient. So what are those maneuvers? They're maneuvers where you want to make the heart more likely to obstruct on itself. So we said that thick septum is getting in the way of the blood as it's trying to pump out of the heart. So what are ways you can make the heart more likely to obstruct? Well, if you make the cavity smaller, then that big septum is going to take up even more room and it's going to obstruct the blood flow. So how do you make the cavity smaller? You make the cavity smaller by dehydrating someone, reducing the preload, the venous return, the blood flow to the heart. And one way is Valsalva, bearing down, tensing your stomach muscles, increases your intrathoracic pressure. So you reduce the blood flow to the heart. So you make the cavity smaller. You make the septum relatively bigger, more obstruction. So Valsalva is one of the most common things that's used. Amyl nitrate, I think, used less often as a vasodilator that accomplishes the same thing. Some people like to do a postprandial. So if you eat and you have splanchnic vasodilation of blood flow, you'll have decreased venous return. Exercise will do the same thing as a peripheral vasodilator. So stress echocardia. So my usual algorithm is always do the easiest thing first. So rest. If I get it, I'm done. If that doesn't work, Valsalva. If I get a gradient that's diagnostic, done. And if the Valsalva doesn't work, then go to a stress echocardiogram.
Sounds great. So obviously some patients are very difficult to see the heart, the chest is large, or they have COPD and you can't see the heart very well. Or sometimes you have some such localized hypertrophy of the muscle that you could miss it on the echo, particularly from the apex when your beam is going like right along in parallel to that muscle wall. So MRI has really become an incredible, technique where the resolution is really phenomenal. I mean, it's, there's non-ionizing, radiation. There's no radiation. And of course, you can give contrast and get even, more information. Do you use the MRI much in your center?
Yeah, I think there's two reasons to do the MRI. One is if the diagnosis is in question, exactly as you noted. If you can't quite see well enough, then you need an MRI to help you see better. You'll get so much better visualization of the myocardium with the MRI. So if you're not sure if there's actually hypertrophic cardiomyopathy, if there's apical hypertrophic cardiomyopathy, the MRI can really help you there. And the second reason MRI can be helpful is in patients for risk stratification, because there are certain findings on MRI that predispose patients to a higher risk of sudden cardiac death. And so for prognostic management decisions, you may rely on an MRI in that situation. So the guidelines relegate MRI to use if the echocardiogram does not offer you the information you need. And I think that's appropriate from a resource utilization standpoint. They are more expensive, but whenever the diagnosis is in question, the cardinal rule of medicine, don't get a test that won't change your management. So if you already know everything from your echo, don't bother. But if you still have lingering questions, I'm not sure if there's hypertrophic cardiomyopathy. Is there the apical variant? What does that apex look like? Is there another diagnosis? I'm still not sure if this is amyloidosis. I need to check for something else. Then the MRI is helpful for you.
Yeah, that tissue characterization, whether we use a T1 mapping or the LGE, the contrast, the late gadolinium, picking up this fibrosis and how extensive it is. As you mentioned, there's certainly been some report. The more extensive this scarring, that we detect with LGE contrast, the worse the prognosis. So we have obviously the other measures that we could use. We could use the cardiac CT, and we have the cardiac catheterization. When do you use the cardiac catheterization? When do you go to the lab?
Yeah, I mean, in this day and age, almost never. It is the gold standard as first pioneered in the 1960s by Dr. Braunwald, Brockenborough, Mora, with all their beautiful studies to look for left ventricular outflow tract obstruction. But really, the beauty of echocardiogram today is it's so good that it's so rarely performed. And I would even go so far as to say that diagnosis based on hemodynamics is a bit of a dying art, same way the diagnosis of physical exam is, in the sense that we don't need to do it so often, and echo has become so good. So I think it's rare simply for diagnosis to go straight to the cardiac catheterization lab.
Great. So now we know a little bit more about the disease, but this genetic, we know that hypertrophic cardiomyopathy is a genetic disease. Could you give us maybe a genetics 101 on hypertrophic cardiomyopathy, Michelle? You mentioned autosomal dominant. What does that mean?
Yes. So I'm a great person to give genetics 101 since I'm not a geneticist. So I'll give it in the simple terms that I can understand. Perfect. So autosomal dominant means that it's not linked to a sex chromosome. It's linked to one of the chromosomes that just men and women have equally. So there's no sex preference for it. And if we have two copies of every gene in our body, you only need one bad copy of this gene to give you the condition. So that's what autosomal dominant means. If you get one bad copy, you got it. And it means you have a 50% chance of passing it on to your offspring. It means if you have it, there's a 50% chance each of your siblings may have it as well. So that's what autosomal dominant means. And the beautiful studies that have been done, a lot of them by Dr. Cricket Seidman in her lab, first ones came out in 1990 and then subsequently, have shown that there's really at this point 8 genes that seem to be most commonly implicated. It's the like I said, myosin genes, actin genes, tropomyosin, troponin. So if there's an 8 gene panel that's most commonly tested. But here's the problem with genetics. The diagnosis does not rest on the genetic testing. You do not need genetic testing to make the diagnosis. If you have a red flag, red herring, this is a bad gene, yes, it will give you the diagnosis of hypertrophic cardiomyopathy, but a negative genetic test does not exclude the diagnosis. So when we talk about why you get genetic testing, in order to make the diagnosis, it's not really, if you look at all series, 30 to 60% of people referred for genetic testing with a clinical diagnosis of hypertrophic cardiomyopathy have an abnormal, one of the clear positive abnormal genetic tests. And what that means is it just reflects our inability to truly understand the entire genetic landscape of hypertrophic cardiomyopathy and what truly constitutes abnormal versus a variant versus normal. So genetic testing is nice because we know that if you need it, there's 8 genes you can be tested for. There's more extensive genetic sequencing that can be done, but that's not as part of a clinical test. That would be more on a research level. But even if you don't have one of those 8 tests, you can still have HCM.
So basically, this is a clinical diagnosis.
Yes.
I mean, you have hypertrophic cardiomyopathy, your heart walls are thick, and you'd have hypertrophic cardiomyopathy. So why should I do the testing? I mean, I know I've got the disease. I mean, is it to help my family? Does it lead to some treatment possibly in the future that maybe could, target, a certain gene or protein?
Yeah, it's always fascinating. It really comes down to shared decision making. So much of hypertrophic cardiomyopathy is shared decision making. You think about this. If I'm going to jump out of a plane, I'm going to put a parachute on. There's no shared decision making there. There's 100% benefit if I put on my parachute. But when it comes to genetic testing for hypertrophic cardiomyopathy, you really have to dig deep. Why am I doing it? How will my life change because of it? So, it can be useful sometimes for diagnosis in the situation where I think there's something else going on. One of those things I memorized in medical school, like Friedreich's ataxia or Danon disease or Pompe disease or amyloidosis, then I might do a gene panel for those in addition to hypertrophic cardiomyopathy to see if I can come to an alternate diagnosis. So that's one reason genetic testing is helpful if the diagnosis is in question. The second time it's helpful, it's really, as you say, it's for the relatives and for their screening, because a genetic test, if someone who has a classic EKG, echo, MRI, presentation, family history, it won't change much for the person, but it may for their relatives, their siblings, their offspring. And that's tricky too, because then you have to ask yourself, how will it help the siblings and the offspring? Well, it can help them in one of 2 ways. It can help them in that they will now get screening and now know that they have the condition, which will help them be screened downstream. And then if they're negative, they don't have to worry about it anymore. But, in a way, genetic testing absolutely opens up a Pandora's box of what to do with the information. So when I have a patient with hypertrophic cardiomyopathy and they're asking me, should I get a genetic test? I say, it kind of depends. I don't need it for you because I know what you have. How would you feel if they have young children? I say, do you think you would want them tested? And if they say to me, I don't care what it shows, I would never test my kids. I am worried about the fear, anxiety, uncertainty that it would put on their lives, even though there's legislation now where you can't discriminate for insurance or employment purposes based on genetic conditions. I'm still really worried. I'd say, well, then maybe you don't need to get it. you can just tell your siblings, I've been diagnosed, and they can get screening every 3 to 5 years with echocardiograms. You can tell your kids' pediatricians, and they can get screened every 3 to 5 years with echocardiograms. So if you already know the information would be so troubling that you wouldn't want to approach it, I don't recommend the test. What is often helpful, even for people who don't want the genetic test, is genetic counseling. And I feel that whenever you say genetic testing, counseling should be the next word, right? Because you should never have genetic testing without counseling. So you meet with someone with very good experience in interpreting these genetic tests beforehand to do the thought experiment, what will happen to the results? And then afterwards, what do we do with the results? So to sum up, genetic testing, incredibly important. If you're not clear on the diagnosis, you think there's something else going on you might specifically want to test for, or if offspring and siblings will find the information helpful for them to then know what specific genes they need to be tested for to know what their outlook is.
I think that's pretty important. I think you're right. The counseling is probably a better term. But knowing that it's autosomal dominant, if you do have the disease, 50% of your kids can carry the same gene and will need to be followed for sure,
Yes.
for the rest of their life to see whether they develop, this disease later in life. So you definitely, you can help them as well as, the siblings. It's always difficult. I think when you get the results and it's negative, but that means that you don't have to do this cascade testing on everybody, at least, right at this point. There may be some other genes that they find out later, let's say in 5 years or 10 years, that it may be worthwhile redoing, and maybe, a new gene will come along. So where do you get this testing? Can you get it online? Is it like 23andMe?
So there are gene panels. The initial testing can cost in the thousands of dollars. The specific gene testing for relatives, once a mutation has been identified, is more in the hundreds of dollars. Insurance will sometimes cover it. So I think rather than going online and doing it yourself, I think the most important thing is to actually seek someone with expertise, most commonly a genetics counselor or else someone with expertise in hypertrophic cardiomyopathy. So you don't just get a print out of stuff, but you have the expertise to help you put it in context. And the other reason why that's so important is exactly what you mentioned, the variant reclassification. So some things we know, this is definitely a bad mutation that causes HCM because we've got this whole family and there are all these people and everyone who has it has a mutation and no one who doesn't does. Great. Then there's some people who, we know this is not a mutation because we know that everyone who doesn't have it has this thing. But then there's those gray areas where, we tested some controls and this mutation seems like biologically it could cause a problem, but some people have it and some people don't, and we just don't know. And sometimes it is actually a problem with the control population. So if you happen to be African-American or Hispanic or Asian, and the control population used to define the normal variance for that particular gene and mutation is all Caucasian, it's going to be a problem. Is it normal? Is it not normal? So as we get more information and experience and understanding of whether a variant is truly associated with the disease or not, we'll become better. So that's variant reclassification. Every few years, have you gone to a genetics counselor who's helped you through the testing? There is that process of reevaluating your test to see if anything has been reclassified as a problem or not a problem moving forward.
Well, that's great. So let's start talking about treatment. And obviously you mentioned, the problem with sudden death, and that's what we want to prevent. First we want to prevent sudden death, and maybe we could talk a little bit about indication for a defibrillator, because this is not an easy, particularly when the patients are so young. You did mention, that it's the number one cause in athletes, and sudden death in athletes. It's almost 40% is due to hypertrophic cardiomyopathy. The rest of the time, maybe 15 to 20%, you have this anomalous coronary arteries. And with those two, you have about, 50% of your sudden death in young athletes. But are there some risk factors? So let's say you see a patient with hypertrophic cardiomyopathy. What kind of tunes you in to this person is probably at risk, for sudden death, and I'm really going to try to monitor it and probably, kind of recommend an ICD more on these patients versus some others.
It's really tricky. I mean, in a way, it's one of the many things we do in medicine where we're trying to predict the future. You just don't know. Well, there's the easy one. The easy one is if they have been previously resuscitated successfully from an episode of sudden death, ventricular tachycardia, or ventricular fibrillation. Then you put in a defibrillator because you know that doing the same thing twice and expecting a different result is the definition of an insanity. And you don't want to do that. So you put in a defibrillator for secondary prevention. Everyone's happy. It's those patients who look good and feel good, who are relatively young, who you know may or may not be a ticking time bomb. And you know that a defibrillator does not come with zero risk. It is an invasive procedure. There is the small chance of a misfire, of an inappropriate shock in a person who otherwise feels good. So you know a defibrillator will not help them feel better. It may help them live longer, but you have to choose wisely. So the guidelines give us some good guidance on who should get a defibrillator for primary prevention. Never had an event before, but I don't ever want one to happen. And so the classic ones are a family history of sudden cardiac death. So it's one or more first degree or close relatives, so brothers, sisters, parents, kids, who died suddenly under 50 or under. Why? Because that speaks more to this is likely a hypertrophic cardiomyopathy as opposed to, well, something was going to get them anyway. This could be something genetic. And that's why that family history is so important. Did they drown at the age of 25 when they were a really strong swimmer? Did they get into a car accident and no one knew why? So there are subtleties of the family history that are important to tease out because they have treatment ramifications. The second thing is massive left ventricular hypertrophy above 30 millimeters. Anywhere from 28 to 30 millimeters, you really worry because that is so not normal. That muscle is so disorganized. Those patients are at risk, higher risk for sudden death. Unexplained syncope, unexplained fainting. Another reason why the history is so important. So if they tell you I went in to get my blood drawn on a really hot day and I'd eaten no breakfast and no lunch and then I fainted, probably not an arrhythmia. But if the patient says, I was just jogging and all of a sudden, I can't remember what happened. I felt great. Then I was down and I don't know how long I was down for. And that's a little more scary, right? What could have predicted that? And apical aneurysm. So for whatever reason, if there's thinning of the apex of the heart, that is a very high risk for sudden death, such that it becomes an indication to place a defibrillator. Now, we were talking earlier, when you're doing your echocardiogram, sometimes you miss the apex. Sometimes you don't get a good view of the apex. There are actually imaging studies to suggest that 50% of apical aneurysms are missed on echocardiogram. Some contrast echo can help, but an MRI is really useful in this situation. It could change management. And finally, if their ejection fraction is 50% or less, so normal EF, 50, 55 or higher, we normally think of heart failure as 35% or less, but because patients with hypertrophic cardiomyopathy have super hyperdynamic hearts, really 50 is not good, not normal. So 50 or less puts them into the heart failure realm. So if you have any one of those things, family members who died suddenly, massive left ventricular hypertrophy, unexplained fainting spells that are unexplained. You can't say they were dehydrated or vasovagal. Apical aneurysm, EF 50% or less. The guidelines tell us, based on the observational studies, that these are the patients who will benefit from a defibrillator.
I had also one of those patients who used to drop his pressure, on the treadmill, because of this, gradient that was so important for him, and we did refer him for an ICD. Well, obviously, there's always room for improvement, right? As you mentioned, sometimes the patient get inappropriate shocks, but all you need is a certain number of appropriate shocks, and you save some lives. There are some complications as well. So there are some other factors. You did mention this apical aneurysm, which really kind of involves the mid cavity. The prognosis is really so bad. These patients, tend to die. The prognosis is very poor. What about the MRI and the fibrosis that you detect on the contrast? Is that, we know it tends to kind of show more arrhythmias or sustained VTAC or non-sustained VTAC. Is that actually coming along the guidelines?
Yeah.
Or something you could consider?
Yeah, the guidelines consider late gadolinium enhancement as a measure of fibrosis of 15% or more of the left ventricular mass, or non-sustained ventricular tachycardia as measured on an ambulatory monitor to be risk modifiers. So there's the 5 big ones we talked about. These might lean you one way or the other, but it's tricky. Say a patient has no personal or family history, no massive LVH, no syncope, no apical aneurysm, no low EF, but they have some gadolinium enhancement, but they have some non-sustained VT. What are you supposed to do? That's really, really hard. Those are the patients that I wake up at night and I'm not exactly sure what the right decision is. Will I sleep better if I put a defibrillator in them? Will I sleep better if I don't? Will they sleep better with a defibrillator? And those really, as we'll get to, really come to the expert analysis, expert discussions, consultation at the hypertrophic cardiomyopathy centers, because now you're getting to the gray area where it's not clear, it's not 100% clear a defibrillator is needed.
Also, when you do your genetic testing, you have these patients that have double mutation. I mean, I guess these also tend to be more at risk than some others that, that have just one gene, which is the most common type. Well, very good, Michelle. We've talked about the prevention, the primary and secondary prevention of sudden death. But now we have all these patients that suffers from the inefficient filling of the heart, of the left ventricle. They're short of breath, or they have chest pain, or they have, syncope. And we know that patients that have these gradients, they tend to progress more to advanced heart failure symptoms and to advanced heart failure death, even sometimes, with strokes. I mean, patients with obstruction have, they're twice as likely to have this poor outcome compared to patients that have no obstruction. So obviously we need medical therapy. There's a lot out there. What is your first line of therapy when you want to treat patients with hypertrophic cardiomyopathy?
Sure. So to take hypertrophic cardiomyopathy with the dynamic outflow tract obstruction first, the key is, as you said, their symptoms are mainly shortness of breath as well as chest discomfort, and you titrate the treatment to fix the symptoms. And because the heart's just beating too forcefully, getting in its own way, you want to relax the heart. And the initial studies in the 1960s were done with beta blockers, and that remains to this day the standard approved available therapy for patients with hypertrophic cardiomyopathy with obstruction. So beta blockers are the first choice, titrated, as I said, to heart rate, blood pressure, symptoms. You do not titrate to the gradient on the echocardiogram because the gradient is dynamic. They ate a big meal, they valsalva, they stood on their head. Who knows what could happen? You want to do it to their symptoms. You get the beta blocker as high as it can go, first choice. Second choice would be a calcium channel blocker like verapamil or diltiazem, the non-dihydropyridine. You would not give the calcium channel blockers like amlodipine, which are vasodilating, which would be horrible and make them feel worse. You'd give one of the non-dihydropyridines. The reason why beta blockers are preferred over verapamil is because they have no vasodilatory properties, whereas verapamil might have a little. If beta blockers alone don't work, maybe you'd add verapamil. If beta blockers aren't tolerated, you might go to verapamil. The next line, if beta blockers and or calcium channel blockers aren't working, would be disopyramide. So disopyramide is an antiarrhythmic that happens to be an incredibly potent negative inotrope. You never give it alone because it can enhance AV nodal conduction. And so if the patient were to go into an atrial arrhythmia, it could go too fast in that arrhythmia. It's always given with a beta blocker most commonly. And so the standard algorithm would be try the beta blocker. For me, the beta blocker doesn't work. I don't usually switch to a calcium channel blocker or add a calcium channel blocker. I go straight to a beta blocker plus disopyramide. Just seems like it works the most effectively. And some patients, you put them on that combination, they feel like $1 million. Life is great. Everyone's happy. I'll still check an echo on a yearly basis. Not looking at the gradient so much, but looking, is there an apical aneurysm? Is there a fall in ejection fraction? But they titrate to symptoms and they feel good. So if you can get there, it's amazing. So is now a good time to talk about mavacamten?
Well, that was the big news at the European Congress of Cardiology.
Yes.
So we have this new small molecule, treatment, new development in the treatment of hypertrophic cardiomyopathy. Let's go ahead. I think it's very, very interesting finding.
Oh, it's so interesting, right? To actually, because if you think about it, every other therapy for hypertrophic cardiomyopathy kind of skirts the issue. Well, the heart's too strong. Let's make it relax. Well, they can get a ventricular arrhythmias. Let's put in a device so if they happen, we can do something about it. This small molecule actually takes the problem where it happens, the actual level of the myosin filaments. How exciting. It inhibits them, so it relaxes the heart directly, not indirectly through a beta blocker. And so the initial study, Pioneer HCM, small, 20 patients, 12 weeks, they found that their left ventricular outflow tract obstruction and their oxygen consumption as a measure of functional capacity with exercise improved. Then there was the larger trial that just came out, as you noted, the Explorer HCM trial, over 400 patients, 30 weeks, obstructive hypertrophic cardiomyopathy. Symptoms got better. Maximal oxygen consumption as an objective measure of functional capacity improved. Very, very exciting. I am most excited, in fact, about the 5-year extension of Explorer HCM because I can't wait to see what happens in more longer term. So I think that's really exciting. And then there was the MRI sub-study of Explorer. So let's see what's actually happening on an imaging level to these people who are getting this tiny little myosin inhibitor. And lo and behold, the heart muscle looked better. It was less big and the dimensions looked better. So it's all very, very exciting. It's an exciting, brave new age for hypertrophic cardiomyopathy with disease-specific therapy. I believe the company is going to be putting in a new drug application to the FDA sometime in early 2021. So stay tuned. We'll see what comes of that.
So I think that's great. We had almost 60% of the patient that reduced their gradient, to less than 30 millimeters of mercury. So that's very significant. Of course, you still had about half the patient that were still symptomatic. They were still class 2 and class 3 remaining. Some patients still had very large gradient. Maybe a quarter of them, had gradients even greater than 50. So it's not perfect. There are some side effects. Obviously, you're trying to work on the sarcomere, on this protein of, so it doesn't contract. But in some patients, they develop some low ejection fraction. We have actually kind of a few patients that develop that, but isn't it reversible? I mean, when you stop the drug, all the effects kind of go away, don't they?
Yeah, and I think the challenge really becomes in phenotyping. If you have it's almost like when you think about cardiac resynchronization therapy for people with heart failure with reduced ejection fraction, 30% non-responders. Why? It's just probably we're not getting at the right people. And I think it's probably the same here. My hope is, even though subgroup analyses are purely hypothesis generating, they will offer some insight, especially in the longer term study, of who is this best for and who is it not so great for. I totally agree. That's really where we need to pinpoint the effect.
But clearly, I think we're seeing the beta blocker and disopyramide. You had, some mild effect, maybe 30 to 40%. And now you're really kind of increasing, your impact, on the patient yes. and on their symptoms, as well as their exercise performance. So I think this is great. But we know what works is this, septal reduction therapies. Obviously we have two options now. We have the surgery, but we have also the alcohol septal ablation. So tell us a little bit, Michelle, explain to our patient, what is a septal reduction therapy? What does it do? Maybe you want to start with the alcohol or sure. with the gold standard?
Sure.
Okay.
Sure. So we'll talk about the principle first. So, as we said, the heart muscle is too thick. Most commonly, it's the septum that's too thick. And the septum gets in its own way when the heart is trying to pump blood out to the body. And that's the problem that causes a lot of the chest discomfort and shortness of breath. Well, we talked about ways we can make it better by making the heart just beat less forcefully. So the septum is still thick. It's just not causing as much of a problem because the heart isn't slamming itself together to pump the blood out in its hypertrophied way. But in an even more direct way is just get rid of that thick heart, thin down that septum that's causing all the problems and the obstruction. So there's two ways to thin down the septum. One is to shave it off, crack open that chest and shave out that septum. And the second way is to cause a controlled myocardial infarction, which to me as a non-interventionalist, Dr. Bouchard, sounds exactly as scary as it is. So a controlled myocardial infarction, a bit of an oxymoron to my non-interventionalist ears, where you make the cells just in that part that are super thick die, and so it becomes thin. So an alcohol septal ablation, inject alcohol, which kills heart muscle, into a tiny little blood vessel that you're pretty sure controls the part of the septum that's causing the problem, so that part gets thin, as opposed to surgery where you crack them open and you whack it out. So there are benefits and risks to both options. So surgical myomectomy is the gold standard. It's the gold standard because it's been around the longest. It was the great Dr. Morrow himself who in the 1960s really pioneered this technique, which has then gotten even better since then. And while the mortality used to be on the order of 10%, the mortality now in the current era is 1% or less. So it's really become an acceptably, from a risk perspective, procedure with benefit. I mean, really dramatic benefit when you think about myomectomy, in that the vast majority of people have no gradient, no symptoms, which is sustained durable response. And there have been now studies with surgical myomectomy following patients for years, decades, with good response. On the downside, you have to crack the chest open. On the upside, you can also address other things. They have some coronary disease, that mitral valve apparatus, which wasn't inserted properly. You can fix that as well. Or what if it's not the septum? What if it's the apex? What if it's the mid cavity? Hey, let's shave that off as well. You can deal with a lot more surgically at the cost of cracking the chest open, maybe causing a defect in the ventricular septum if you shave too much. Though in experienced hands, greater than 90% chance patients will feel great, less than 1% chance something horrible will happen to them. So contrast it with the alcohol septal ablation. Sounds nice. Just put a catheter in my leg or my arm and easy peasy, go up, controlled myocardial infarction with alcohol to this tiny portion of the heart. Well, it is better in that there's less pain, easier recovery, but because you're causing this controlled myocardial infarction, there's a little bit of lack of control in the sense that you can also injure the part of the heart that controls the electrical system and cause complete heart block requiring a permanent pacemaker. That can happen with surgery, but much less often. You can also cause injury to the coronary artery, like a dissection. You can cause a pericardial effusion. You can cause a way bigger heart attack than you meant to cause. And it doesn't work perfectly in that something on the order of 7 to 20% of patients, depending on the series, depending on the experience, require a repeat procedure. So, and it doesn't work if you got a problem anywhere but the proximal septum. It doesn't work if you also have a mitral valve that might need fixing, or you have in that situation. It won't work if there's apical or mid-cavity obstruction. So really what it comes down to ultimately is shared decision-making. No one quite knows the right answer. You're taking the gold standard, which we know will probably work forever, but it is a major surgery. And you're contrasting with a more minor procedure that might not work as well, but you can always do it again, maybe, if it doesn't work, or you can switch to surgery. They've never been tested head to head, but we can say that intermediate outcomes are the same as far as mortality. More pacemakers, more repeat procedures in the alcohol ablation arm. So I think it's a very tough decision. And it's the kind of thing where I go through that with the patient and I say, we want you to feel better. Both will help you feel better in the short term. Longer recovery from a surgery, shorter recovery from ablation, may need more procedures in the future with an ablation. Let's talk about it and figure out what's most important to you. What do you most want to avoid? What are you most looking forward to?
So let's sum this up. I mean, there's a lot of information. So basically, we're dealing with patients. They're on maximal tolerated medical therapy, and they're still very symptomatic. They say they have symptoms of heart failure, or they have a lot of chest pain. Their gradients are still very high, greater than even 50 millimeters of mercury. So these are our candidate for septal reduction. The gold standard is truly, surgical myectomy. I mean, this is where you get the best results. You have actually 98%, success rate. I think so. This is very good. And I think if you're dealing with a young patient or a young patient less than 40 years old that has no contraindication to surgery, probably we should head toward the gold standard in septal myectomy and really get the best long-term results. But for the patients that have, some increased risk, comorbidities, septal ablation is a good option, particularly in experienced hands in centers that do a lot of them. I mean, I don't think I would go to, a center that does maybe just 1 or 2 a year, but someone who's got experience because, obviously you're creating an infarction, you're creating an area of necrosis. You have to watch very carefully. You have more ventricular arrhythmia afterward, VFib, VTAC, you can die from this. You may need a pacemaker. So I think it'd be kind of a good idea to have someone that has some expertise, with the technique, but, a great alternative. And if it didn't really kind of completely, control the symptoms or the obstruction, it could always go, to surgery if it is a possibility. So I think it's kind of, great treatment. Well, we've talked a lot about the septal ablation reduction therapy. We've talked mostly about this, obstructive, form of hypertrophic cardiomyopathy. But there's like this 30% of patient population that has non-obstructive cardiomyopathy. That means they have kind of a thick muscle. You don't have this gradient across, the outflow tract. How do you treat these patients? I mean, because they still have somewhat, increased mortality. I mean, you develop heart failure, you can develop VTAC, they may need an ICD. How do we treat these patients, Michelle?
They're the hardest to treat, honestly, as the non-obstructive hypertrophic cardiomyopathy. My first question always is, am I really, really sure there's no obstruction? So you'll really put them through the gamut of the echo and the echo with Valsalva and the stress echocardiogram to make sure you're not missing something. But what you're left with generally is that heart muscle is just so stiff that it has a hard time relaxing. And when in diastole, when it's filling with blood backs up, less efficient, more shortness of breath, chest discomfort related to that. So the treatment is in essence the same: the beta blockers, calcium channel blockers, diuretic therapy. Often cautious use of diuretic therapy in these patients is very helpful as well, because they can get the volume overload physiology that leads to the elevated intracardiac pressures, pulmonary capillary wedge pressure, filling pressures, and shortness of breath. Now, mavacamten has been tested in a phase 2 trial in a non-obstructive, that's the Maverick HCM trial, and in patients who were not obstructive over 16 weeks, NT-proBNP, troponin I biomarkers got better. So we'll have to see if that's borne out in a larger study with longer follow-up to look at symptoms. So that may be an option for these patients. There are other things that have been tried without a lot of good benefit so far. Angiotensin receptor blockers, losartan was tested in such patients, no benefit. Valsartan, there's going to be an ongoing trial of valsartan looking at actually just gene carriers to see if there could be benefit of the angiotensin receptor blockers. And then the angiotensin receptor neprilysin inhibitors, the holy grail now for heart failure with reduced ejection fraction, is being tested in hypertrophic cardiomyopathy, but stay tuned, no information yet. So I treat non-obstructive hypertrophic cardiomyopathy very similar to how I treat heart failure with preserved ejection fraction or garden variety HFpEF. You really treat the symptoms because you can't treat the underlying cause. You really have nothing to target, like an outflow tract. You treat them with the beta blockers to relax the heart and the diuretics to relieve congestion if present.
Do you think there'll be a role for the SGLT2 inhibitors?
Well, they seem to treat everything else. I hear there's a randomized controlled trial of toe fungus, and it's really great. So probably.
challenging, but I think you're right. It's the treatment of HFpEF. It's very difficult. We had a whole podcast on it. And, of course, you have in the HFpEF non-hypertrophic cardiomyopathy, you have a little bit more comorbidities, which could coexist, as well in this patient population. But beta blockers is your first, treatment of choice, as well as diuretic like spironolactone, like you mentioned, and potentially, maybe the valsartan as it can reduce fibrosis, in certain patients. Well, let's talk about AFib, briefly, because if you look at patients with hypertrophic cardiomyopathy, AFib is probably the most common arrhythmia, and it causes so much trouble. I mean, it really, the patients do not tolerate going at 150 miles per hour, and particularly losing that atrial kick that you have when you have the atrial fibrillation. What is your treatment strategy in patients with AFib and hypertrophic cardiomyopathy?
Yeah. So whenever you think about someone with atrial fibrillation in general, you think about three things: rhythm control, rate control, and anticoagulation. So let's talk about anticoagulation first, because that's easy. Of course, patients with atrial fibrillation are at increased risk for stroke. In non-HCM patients, we risk stratify them with the CHAD-2 VAS score. And if their score is high, we put them on anticoagulation to reduce their risk of thromboembolism stroke prevention. In patients with hypertrophic cardiomyopathy, de facto, they are at high risk for stroke. You don't need to risk stratify them. All you need to say is AFib plus HCM equals anticoagulation, whether it's a vitamin K antagonist like warfarin, whether it's a DOAC, direct oral anticoagulant, whatever it happens to be, they need to be on anticoagulation regardless of any other risk factor. HCM is enough to buy them stroke prevention anticoagulation. So that's easy. The next part is, well, how do you treat their symptoms, their symptomatic palpitations? And as you said, they're going to be symptomatic because their hearts rely so much on the atrial kick to maintain their stroke volume with hypertrophic cardiomyopathy. So rate versus rhythm control, there's no particular trial in patients with hypertrophic cardiomyopathy. I always start with rate control because it's easy and less risky. If you have to go on to rhythm control, I'll often phone a friendly electrophysiologist because, gosh, amiodarone, I know it's pretty much safe in everyone, but this patient's only 40 and I don't want to subject their liver and their lungs and their thyroid to another 40 years of amiodarone. Make me feel comfortable with giving them something else. So there's that issue. And then when it comes to ablation, there's no head-to-head trials, but patients with hypertrophic cardiomyopathy who undergo ablation for atrial fibrillation, it tends to be less successful than patients without a hypertrophic cardiomyopathy. Maybe if you get to them earlier, maybe before they've had too much remodeling of the heart, it'd be maybe beneficial, but that's not clear. So my personal philosophy is, if I anticoagulate everyone, if I can get by with a little beta blocker and everyone's happy, we're all happy. If I need to go to an antiarrhythmic, at that point, I'm just calling up the electrophysiologist and saying, listen, can you just try to ablate them now early? Maybe it'll work and then we'll be done. I don't have to think about it again.
I think it's a great idea. I think we need to be, particularly these are young patients, a lot of them, and you want rhythm control and get them back in sinus rhythm so they can function better. Sounds like a good plan, and anticoagulate everybody with AFib and hypertrophic cardiomyopathy. Well, let's talk about lifestyle changes, and particularly want to focus on exercise because there's limited information on the risk in hypertrophic cardiomyopathy across the age group and the activity level. There is variation in severity of the disease itself, as well as it's a progressive condition, which varies, across the age group. We know exercise is good. I mean, we prescribe exercise every day to all of our patients. We know it improves cardiac health. Patients feel better, improves heart function, increase exercise tolerance. And it seems like a lot of the recommendations are made because for the athletes, that do really very strenuous exercise, really high intensity, which obviously can cause arrhythmia, can cause increased obstruction. But what do we do for the normal folks, like you and I and our patients?
Yes, you and I, because I can say, at least for myself, I'm not a highly tuned competitive athlete. Yes, exactly right. Exercise is important for patients with hypertrophic cardiomyopathy, just like it's important for every one of the rest of us. So the RESET HCM trial took 130 some odd patients with hypertrophic cardiomyopathy for 16 weeks. Either put them through a moderate intensity exercise program, cycling, walking with jogging, elliptical training, and then told the other half, just do what you want. And after 16 weeks, there was better exercise capacity as measured by their maximal oxygen consumption in the patients who were put through this 16-week training program. And while the study was small, so it wasn't really powered to assess safety, there were no dangerous, awful ventricular events or arrhythmic events or otherwise in the patients who exercise. So the take home from this, which the guidelines support, is that these patients should exercise, moderate intensity exercise. What does that mean? Brisk walking, social tennis, swimming, gardening, elliptical. That's all great. That's wonderful. That's fine. It's highly encouraged and you should do it. When it comes to more strenuous, which really I equate to competitive sports, meaning you're trying to excel against someone, against a standard, that's a complete unknown. You have, we always like to say in medicine that the plural of anecdote is not data. No, so much more is that ever true there than the era of COVID. But even before COVID, that was true. When you think about the athlete who dropped dead suddenly on the basketball court, and it turned out that he had hypertrophic cardiomyopathy. Will any doctor ever again let a patient with hypertrophic cardiomyopathy play competitive sports? And it becomes a really tough decision. There's things we know we can't do. We can't risk stratify them like we'd risk stratify you or I, meaning we can't say to ourselves, no massive LVH, no syncope, no apical aneurysm, you're going to be okay, because we have to hold them to a different standard because their risk is going to be higher based on their activity. You also can't use genetic testing. It is not at the level of risk stratification yet. It really becomes shared decision-making, really at a center with a lot of expertise in making these decisions. And there's also that aphorism in medicine, the more you know, the less you do, or the more you know, the more likely you are to be able to say okay or yes or no. I think this is what it comes to. You really need a center with experience, a consultant with experience. And I think the guidelines really phrase it very beautifully when they talk about the shared decision-making around exercise. The guidelines basically say precise risk is not quantifiable. It likely differs over the enormous spectrum of physical activity. There's opportunity for flexibility, individual responsibility, and choice. So, I think you have to put all that together. And I think it becomes so critically important when you have a high school kid whose future he and his family believe hinges upon the sports scholarship to get him to a better place in life. And are you denying him? Are you not denying him? How much of his future are you truly impacting? It becomes a really tricky thing. So I think you keep in mind how much is unknown and how much has to be, how much of that unknown and uncertainty is shared with the patient based on their goals.
Do you do stress echo in your lab to determine how someone maybe is able to perform, at least to help them with making a decision?
The only problem with the stress echo is if it's normal, it doesn't mean they're okay. And so you might have a normal one, and then a week later, which I think actually has happened in sports history, you have a normal stress test, and a week later have a catastrophic event. So I almost think that might be counterproductive in the sense that you can't rely on that. I suppose if they have an event, that was easy, but the chances are, in general, the event rate is low. It's hard to know what to do with the information.
I guess there's certain things that, that make sense. You need to stay hydrated. Yes. And, drink lots of fluid, and not only water, but, we recommend a lot of Pedialyte times where you really increase your volume inside your heart. And I guess you have to recognize the symptoms. Do you actually prescribe exercise according to the METs or level of effort, or 5 METs is pretty, kind of low level of exercise.
Yeah. What I usually tell people is, because honestly, I almost have to look up the METs every time myself. I tell them walking, social, doubles, tennis, elliptical, swimming. I say, you should be able to still carry on a conversation. You're not gasping for breath while you're doing it. You're in a light sweat by the end of the workup. I sort of give those parameters. And for most people, that that gets them to a level that's not dangerous. I tell them you're not competing, you're not trying to exceed or beat a goal, you're just trying to stay conditioned.
It probably makes sense also to have, if you don't have an ICD, at least to have an AED portable, and maybe not to go exercise in the wood,
Yes. Yeah. Exercise with other people, I think, is key. Hydration and have a training buddy wherever you're exercising is key. Absolutely.
Yeah, very good. Well, that's very helpful. What about centers of excellence? I mean, we've talked about, centers. If you have a patient with hypertrophic cardiomyopathy, where do you go to get, the best evaluation and maybe advice if you're a patient?
Yeah. I think it comes down to really, any physician can make any physician should make the diagnosis, at least the initial diagnosis. I'm worried about these symptoms. This EKG looks funny. Let me get an echo. I think that is something I would hope we empower every physician out there to do. But once you have that echo and you're not quite sure what to do next, exactly right. You need a center of excellence, a center of experience. The guidelines refers to it as. And they talk about there's primary hypertrophic cardiomyopathy centers versus comprehensive hypertrophic cardiomyopathy centers. The 2020 guidelines go through what constitutes one versus the other, but it basically is a center where there's experience in genetics, genetic counseling, genetic testing in order to understand the consequences of testing. There's expertise in arrhythmias like the atrial fibrillation, the risk stratification for sudden death, valve disease, heart failure, up and including to heart transplantation, which in a minor subset of patients may be indicated, and also the interventional and surgical procedures, because it's so clear, as with many things in medicine, volume matters, volume guides competence and good outcomes. So how to find those centers? The Hypertrophic Cardiomyopathy Association has a very nice section where they offer information on that. And I think in general, for physicians or patients, I think the local tertiary care, quaternary care center in your area, the university center in your area, certainly would be the referral place to start. And if someone there is not experienced, they would certainly know how to route the patient to the best fit.
But it seems like those centers of excellence really adopt, what we're trying to preach in medicine is really that multidisciplinary approach, the heart team approach with a cardiologist and an invasive cardiologist, an electrophysiologist, a cardiac surgeon that has experience with septal myectomy, a geneticist, a sports cardiologist, So I think it's really kind of the team that really kind of helps the patient and their family.
Yes.
So I think that's a very good point. Well, Dr. Michelle Kittleson, I mean, everything we wanted to know about hypertrophic cardiomyopathy. We want to thank you very much. I mean, this was kind of a great attribute to our patients as well as, for our physician to get an update on the field of hypertrophic cardiomyopathy. Thank you for your involvement also with the American Heart Association and college. Your contribution is very, very important, and we thank you for that.
Oh, it's been absolutely delightful. Gosh, so much. I'm not sure you needed me, but it was so much fun to talk about hypertrophic cardiomyopathy.
Thank you, Michelle.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.